Okay, thank you. So this is another topic that is quite controversial. So I myself have been working a little bit on it, but most of my work has been coming from one of my former New York fellows, who is now a professor in Oslo, Norway, Dr. Ignatovic. So I will share a lot of his work, basically, and tell you what I think. So there's a lot of, it's important to understand one thing for the young surgeons, that when we do left colectomy for left side colon cancer, we generally do D3. What do you mean D3? We do dissection of the third level because we take the IMA, we divide the inferior mesenteric artery from the aorta. That's an easy procedure that everybody should be able to do in colorectal surgery. But when we operate on right colon cancer, we don't do the same. We don't go to the very root of the vessels because of some anatomy issues that I'm going to go into. So the earliest I can see a definition of what we should do for colon cancer is here. It's from a long time ago. And it basically says, you see, you can remove a considerable length of gut. Basically, it doesn't say how many centimeters, you know, what vessels you should remove. The growth is, in English, a way to speak about the tumor. The primary glands will be the lymph nodes and the vessels. So this is from 1909. Now, there is a lot of nomenclature, a lot of names out there. I just wanted to express that I tried to clarify this in an editorial in colorectal disease years ago. What is a high tie? A high tie is not a D3 like it is in left colon or in rectal cancer. And the complete mezokolik excision, which is an acronym that comes similar to the total mesorectal excision for rectal cancer, is basically a D2, still a D2, but it's dissecting along the embryological planes. So what is different is that D3 lymphadenectomy is a way to push the lymphadenectomy to the left of the superior mesenteric vein, taking the anterior layer of fat that is covering the superior mesenteric vein and artery, but it's not going posteriorly, which is another definition, which is the D3 extended mesenterectomy, which is taking also the lymph nodes that are behind the superior mesenteric vein and artery, and which is a difficult operation, very controversial because of the risk of injuries. And the question would be what would be the yield, and what would be the benefit, to the patient of doing this operation. So this is a typical Japanese description with numbers for each lymph node. This is for the residents, there are all the young surgeons that are there. This is D1 lymphadenectomy. This is D2, which we normally do. And this is D3, which takes the lymph nodes that are all along the superior mesenteric vein and artery. This is the classical paper from a German surgeon, Hohenberger, who was basically he was not doing D3 lymphadenectomy. I just want to clarify that. CME, complete mesokolik excision, is not D3, but it is a medial to lateral dissection, which is what I do along the embryological planes. So, and it's an important concept. You don't want to go into the muscularis propria or the intermesocolic plane. You want to go into the embryological plane and do not breach the fascia that is the envelope of the mesentery of the right colon. In this case, this is the terminal ileum. And of course, when you look at open surgery, this is a courtesy from one of my previous pathology friends from my previous tenure, Stony Brook. she was showing me how, you know, in open surgery, some surgeons, they get a great amount of, I mean, the surface, I would say, of the mesentery in laparoscopic surgery can be sometimes questionable. You can see here the ileocolic vessel. You can see the mid-colic, but there's a big hole here. So we know of the embryological planes. We know all this from rectal cancer. The anterior dissection, rectal cancer, all these concepts, Denonvilliers fascia, are coming from rectal cancer and then applied to colon cancer. Another question is what is the number of lymph nodes? This has been going on for a long time. They were claiming that it has to be 12. There are recommendations that are essentially grade C, meaning not grade A or B, because there are no randomized control trials. And strange enough, the National Cancer Institute guidelines in the United States are based on one observational study in the UK with only 103 patients from 1989. So, but a lot of societies have in the United States approved the number 12 for lymph nodes. Some others disagreed, and some other, you know, even correlated a number to improve survival. And Medicare is one federal insurance company that, you know, pays back, you know, reimburses, you know, the hospitals. So, and Dr. Fleshman is an excellent colorectal surgeon who is describing this article that four lymph nodes are required. So basically, you know that all this depends not only on the surgeon, but depends also on the pathologist, you know, that you have. And so there are a number of factors that are playing into this number of lymph nodes. Now, this is a study from Korea that I found very interesting because they are describing what are the chances, what is the percentage of metastasis that you can have in the D3 station, meaning the one that we technically don't remove. In sickle cancer, it's 11%. Then in ascending colon, you can see you can add up these two. That is a little bit less. This is the right colic, and this is ileocolic. You see, right colic D3, ileocolic D3. And then the flexure is getting worse. You see, you have 8, 4.3, 4.9, so it's higher. And then you have the proximal transverse is also very significant on the mid colic and on the right colic. So all this is to say what? If you look here on the sickle, you have a fair number of stage 3, 43%, and 39 stage 0.2. But as you move toward the hepatic flexure and the transverse and the proximal transverse colon, you see that the number of stage 2, the percentage of stage 3 is decreasing. So that means that we are not giving, that can result in not giving chemotherapy to patients that maybe they are actually stage 3, but they are stage 2 because we have not done a good job removing all the lymph nodes. Now, Dr. Ignatovic has been studying with me in Norway, and we have done corrosion casting, you know, to study the anatomy. This is something that is good for a young surgeon to understand. This is a simplified anatomy where you can see the ileocolic vessels going behind the SMV to reach the SMA, you know, the artery, whereas the right colic are running in front of the superior mesenteric vein. Now, the result of these studies on corrosion casting are telling you that the ileocolic is always present and is in two-thirds of the cases crossing behind the superior mesenteric vein. for a length of about 2 centimeters. The right colic artery is crossing mostly, 2/3 in front of the sublime penetrating vein, which is, easier to dissect, for about 2 centimeters. These are the pictures, of the results, which are really difficult to read. That's why I'm giving you the numbers. So in the Japanese literature, this corresponds to the same. They call it the surgical trunk. So for a surgeon, it's important to know that the dissection goes from the bottom up, from the ileocolic to the right colic, and then to the so-called gastrocolic trunk of Henle. Is the surgical trunk. So here you have another study on corrosion casting of the gastrocolic trunk of Henle. This is a very dangerous vein, very short, and very easy to rip. Basically, to create an avulsion. If the assistant or anybody pulls on the mesentery of the transverse colon too hard, it can, avulse this vein from the superior mesenteric vein. That can be a very tough situation to control the bleeding. So in the work of Dr. Ignatovich, there are 3 lymph node compartments. You see the gastrocolic trunk of Henle, GTH, the right colic artery, and the ileocolic artery. So one thing is the anterior layer, and one other thing is the posterior layer. Now, Dr. Ignatovich would do, this is an article from his team from Oslo, Norway. They would do a CAT scan, CT angio, as we call it in English, basically a CAT scan angiogram to identify the anatomy of the superior mesenteric artery and vein, because there are a lot of variables. So they want to be knowing the anatomy before they go into surgery. Another work from Norway was addressing the question that if you do this lymphadenectomy on the front and even on the back of the superior mesenteric vein, you're going to cut some nerves. And the question is whether, cutting those nerves, you will increase bowel movements, But, they've been following patients for 6 months and they concluded that they had no bowel movements, issues. Probably this is the most important slide. This author, I don't remember from which Asian country, he published results that you can have skip lymph node metastasis, most of 20% of the patients who undergo D3. So that can result in upstaging cases from stage 2 to stage 3. And again, with the consequences that I mentioned earlier, which is, are you going to give chemotherapy or not? In my cadaver courses, I've been trying to teach this operation robotically. It's actually working very well, to dissect. And this is a cadaver lab. I was teaching how to dissect, you see, this is the fat in front of the superior mesenteric vein, and then, dissect the vessels. But again, you need to do this operation open with a vascular surgeon if you are, starting to do any of this, in patients. So the take-home points are that complete mesocolic excision is accepted, and I think is the correct thing to do. There is really no science on it, but I think that's something we all should do, because there is no reason why we should do a TME and we should do a CME. But we don't really know the science, because it's all the work from Germany is all retrospective. The question of upstaging from stage 2 to stage 3 is a very important one, but it's based on one study only, which I quoted. and that would be in favor of doing D3 lymphadenectomy. The question is whether you are referring to D3 lymphadenectomy, meaning the anterior layer of fat tissue and lymph nodes in front of the superior mesenteric vein and artery, or you're referring to the posterior wall, because the last one would be a problem for surgical technique, and lack of training in general surgery or in colorectal surgery that might require a vascular surgeon. And the question remains controversial whether the risk for complication will be outweighing the benefit of identifying metastatic lymph nodes. That would be all. That concludes my second talk. Thank you.